Good evening, everybody. My name's Fiona LeBroy from Heartburn Cancer UK. Thank you for joining us this evening. I think I'll just start with a couple of quick housekeeping rules, if I may. If you're able to put your microphone on mute, just so that we don't have any background noise, that'd be great. And you can always take it off if you want to ask any questions later on. That would be great. Thank you. Thanks for having your screens on as well. For those of you who are happy to do that, it's lovely to see faces when you're presenting, and just to check that everybody's all right as we go along. We will have the opportunity for questions as we go through, and you can either raise your hand and we'll come to you when we're able to, or you can pop your question in the chat and we'll try and get to you before the end. As you know, you're joining tonight because we've got an expert speaker session. Our guest speaker is Fergus Noble. He's a general and upper gastrointestinal surgeon at Southampton Hospital. He is going to cover the topic of surgical treatments for acid reflux, and we'll pick up on things like links, fundoplication, and the reflux stop procedure. We also have a patient joining us later on in the chat called Anna Lawton. She's had the reflux stop procedure, so she will be able to tell you a little bit about it from a patient's perspective, and you might be able to ask her any questions as well. I think that's everything I need to tell you all. So without further ado, I'll pass you over to Fergus. Thank you ever so much for joining us, Fergus, and sharing your expertise with us this evening.
Good evening. Sorry, I'm just make sure I don't overgo. So what you can expect from me, I don't know if you can see me. I haven't worked out the technology to show a little picture of myself and my talk, but there's a picture up on my first slide. You can expect about 20 to 30 minutes, depending on how many questions we have as we go through. I'm quite happy to field questions as we go. And I'm just going to really give a kind of an overview of what I would say to a patient when they come and see me in clinic. But I'm going to give you a bit more data about how I've come to my conclusion. I'm an upper GI surgeon. I work in Southampton. I work with a number of your trustees, and I'm aware of heartburn cancer. So I've worked in research. My disclosures are, I have had funding from Cancer Research UK for 3 years as a fellowship to get my PhD. I have had funding to be trained in link surgery, and so they've trained me and they paid for the training. And I've had funding from Reflux Stop to do the procedure. Unfortunately, the NHS doesn't fund these things. So, but there you go. I don't think there's any other disclosures I've got. I work for the NHS, and that's it. So we'll just go through the slides. To give you a little picture, the majority of upper GI surgeons in the UK at some time or other do a fellowship at the end of their training, and Royal Adelaide Hospital is famous for upper GI surgery. It was where H. pylori was discovered, and the gentleman swallowed the H. pylori and then gave himself treatment and got rid of it. And it's been famous for upper GI surgeons, and a number of upper GI surgeons around the country go to the Royal Adelaide. 1, because of the weather, 2, because of the wine, and 3, because of the surgery. To travel. And that probably inspired my interest in benign surgery. I do cancer surgery, but I'm interested in benign. So, and I'm going to explain why people come and see me for surgery, because the principal treatment for reflux is going to the pharmacy, changing your lifestyle factors, and taking a tablet, whether that be, Gaviscon, Rene. Then you might go on to ranitidine, and then you might go on to a proton pump inhibitor. So patients come because they don't want to take the tablet anymore, and that may be just pure choice. They may get side effects from the proton pump inhibitor. They failed the treatment, i.e. they're no longer working, or they've got complications of reflux, and that may be a narrowing, difficulty swallowing, respiratory complications, ulcers, bleeding, or regurgitation. Or some people, rarely do we need to do the operation to protect up for example, after they've had a lung transplant. So it's trying to understand, and there's been a kind of critical change in the way we think about reflux disease, and there's kind of three components to the barrier that stops us. There's the lower esophageal sphincter, the valve, and the diaphragm, and they all three work in combination. So it's a matter of having the valve in the right place, which is in the abdomen, not in the chest. And that's, if the valve is in the chest, it's kind of given the term hiatus hernia. And lots of people come along and say, I've got a hiatus hernia, and that's what it means, that it's gone up. And we'll reinforce that as we go through. So the surgery is now we're trying to recreate the valve and put everything back anatomically where it should be. So in a little bit more detail, the esophagus is the tube. And again, doctors like to give lots of different words, the food pipe, the gullet, the esophagus, just to confuse us. And then it goes down into the stomach. You can see the lower esophageal sphincter muscle, but that's not the whole story. There's an angle between the stomach and the esophagus, which needs to be recreated. And you can see the diaphragm. It needs to be well below the diaphragm so that the pressures of your abdomen is working. So it's all three components is what we now think is required to get a good result for you. Now, kind of current treatment options, as I said, is tablets. And you can kind of see, this is a sliding kind of diagram of where we are. So in theory, you know, all patients could have fundoplication surgery, but the majority of people will have medications until they get really severe. So the only people we operate at the moment are people with quite severe disease, because why wouldn't you want to just take a tablet rather than undergoing the risks of surgery? So as things get severe, we're kind of operating on the most kind of debilitating, because it's not just, oh, it's a bit of acid and I feel a bit, you know, the gastroesophageal reflux disease perhaps isn't given all the credence it can be. It can be a completely debilitating disease. Fundoplication is the gold standard in the UK and across the world. That is the operation that the majority of centres believe in and use for their treatment. There's three different types that are commonly performed in Europe, in the UK, and abroad. And the original operation is the 360 fundoplication, Nissen fundoplication. And then there's two partial fundoplications. And so the evolution kind of started with the fact that, you know, people started to realize that, yes, we could treat someone's acid and reduce their acid, but we'd often give side effects to people, whether that be gas bloat, diarrhea, regurgitation, or dysphagia. So there's been a move within the community to advocate for a partial fundoplication, whether that be a partial posterior or a partial anterior. Now, it depends where you were trained, who you were trained by, and you probably want to do what you're good at. You probably don't want to be doing lots of operations. You want to do the operation that you've been taught. I went to Adelaide, where Professor Watson, and he does a Watson anterior fundoplication. So that's why in the UK, quite a lot of people do a partial Watson anterior fundoplication. In Europe, a partial posterior fundoplication called a toupee. Again, we like to have lots of different terms just to make it slightly more confusing. So the reason surgery started to happen is because of a Lotus trial, which was set up in the UK and delivered in the UK. And this was comparing tablets versus surgery. And you can see the time to treatment failure were fairly similar between both groups of esomeprazole and anti-reflux surgery. And there was, when they say treatment failure, that is going back on esomeprazole if you had the anti-reflux surgery, or failing when you had esomeprazole and kind of demanding surgery. What we did notice is that in the anti-reflux arm, i.e. the surgical arm, people had better control of their heartburn, better acid regurgitation symptoms than just taking a tablet. However, why does not everyone have an operation? Is because of the side effects of the treatment. We haven't designed the perfect operation. And I think if you go and see anyone in the UK, people will tell you an honest opinion of what a fundoplication can and can't do. So the side effects are dysphagia, difficulty to belch or vomit, specifically with the bigger the wrap, the 360 wrap, the less likely that's going to be. People feel bloated, fullness. They can get flatulence, which is particularly important, as we're taught in ladies, but probably just as much for men, and diarrhea. So that's where, you know, anti-reflux surgery perhaps got a reputation of, oh, you know, you've really got to be desperate. So we're only operating on the most severe cases. However, as you've seen, the results are still, in our view, in the medical community, which is important, but probably more important for the patients, you know, we're still looking at, for anti-reflux surgery, the fundoplication, that 90% of people were happy at 10 years and 80% of people were off tablets. So, you know, if you were looking at other treatments around for different conditions, you would be happy with that. But this is kind of, it's a lifestyle operation.
Fergus, can I just interject for a second? We've got a question in the chat from Mike Thomas. He's just asking, can you clarify, please, does the fundoplication apply in the case of hiatus hernia only? Gosh, I put my teeth in and speak in a minute. In the case of hiatus hernia only, can you answer that for us, please?
And the simple answer is no. It can
Thank you.
apply to anyone with gastroesophageal reflux disease.
Thank you.
As you've probably seen, you know, the nuance of whether or not patients have a hiatus hernia is difficult to diagnose, even on gastroscopy, even on an X-ray test. It's not always diagnosed until surgery, and it may be that your lower esophageal sphincter has slipped up, and it's just difficult to diagnose. It's worth pointing out, you know, we'll get to that bit about how many people have surgery. So this is around my point of, so doctors spend their time writing papers, and then once we've written enough papers, we can then review all of those papers, and that's called a systematic review and meta-analysis. And this kind of shows that there is a lot of data around fundoplication. So that is why it's the gold standard. And these are patients with follow-up up to 15 years, 3 years, 5 years. So, and they're all randomized trials. So these are the higher quality papers comparing different types of surgery, and they're comparing 360 to a partial fundoplication. And they kind of into, you know, the conclusion of all of these studies is potentially you'll get your reflux back quicker with the partial, but you'll get less problems such as dysphagia along the way. So hence gave rise to some people who believe that you should have a partial fundoplication over a full fundoplication. There are as many, as if you put 10 upper GI surgeons in a room, you will get 10 different opinions, which kind of tells you about the paucity of the quality of the data when we look at this. But you can see across all of those studies, there is still 90% of people happy at 10 years, 80% off tablets. So it's still a durable procedure. To kind of back up the point around we're only operating on this people up here, only 2,000 people in the UK have anti-reflux operations on the NHS, and there's probably a similar number privately. So you're looking at 4,000 operations. If you kind of take a step back, about 40 to 50% of people suffers from gastroesophageal reflux disease, 40 to 50% of the population. So if you take the adult, we're looking at 20 million people, and we're certainly not doing 20 million operations a year, and nor should we. however, there's a kind of a gap of these patients who are getting severe reflux, but they're scared of fundoplication, and they've heard, there's a lot of patient blogs, patient chats, Facebook. Not that I'm on Facebook, I've managed to avoid that generation, but that are talking and have got concerned about fundoplication. Or you don't want a fundoplication, it gives you these symptoms, which we understand, which is why perhaps links came along, and that was started in America. And that's something that we adopted early in Southampton. And, the attractiveness for us was it's going to get rid of those side effects of the gas bloat. And there's less manipulation of the stomach. So there's no wrap, but you're exchanging a wrap for a magnetic bead individually. They're connected up by individual bits of metal, and you can see as the food goes down, they can open up. And we have been doing it for a number of years. It's finally got nice approval. It's gone through all of the correct procedures. Greater than 40,000 of these devices have been put in the UK, across the world. And I've picked out one study because it is the first study, and it's 2024, which is the only study that's reported on UK patients, and it looked at 151 patients. This isn't a randomized trial, it's just someone's experience. So it's one centre's experience in the UK. And they have done 151, so not the 40,000. And they saw symptom improvement, but I think you don't need to be a scientist to realize, well, there's 151 patients and you've only followed up 90 because, trying to get a survey along the years. So you've suddenly got to ask yourself, where have the 60 patients gone? But they've had improvement in 93%. What does that mean? You can see that while they've got improvement, all of the patients aren't necessarily completely happy. But again, you're looking at the 90% range of people who's had a percentage improvement. Did they have gas, bloat, and dysphagia? A reasonable number of the patients afterwards had dysphagia. Were they able to belch and vomit? Yes. And we'll just look into a little bit of detail about this dysphagia, how severe it was. And then the important thing for us as surgeons is how long it lasts. It may be more important for the patient who's like, yeah, but hold on, I had dysphagia for 6 months. But, we're seeing these operations as something to last for a long time. And you can see that 22% of patients, so in this cohort in the UK, so applicable to perhaps you, considering links, while it had very good treatment of your reflux, again, 90% of patients had a good response to reflux, you're still getting a tail of dysphagia that lasted greater than 12 months. It went through the NICE process to show that there was low, I think when you're a surgeon, you worry about putting in artificial things or foreign bodies. And the company has kind of got over the problems with magnets and MRI and their MRI compatible links. They've got over some of the dysphagia issues, as in the technique has changed. We are not putting in the same size of links that they did when they started. So we're learning. And perhaps, the dysphagia rate has possibly gone down, but I don't have the data. But last week we were in London at the European Foregut Society, and they're kind of, people are quoting around the 10% of patients having some sort of dysphagia after links. So it's Achilles' heel. So we got rid of some of the other side effects of fundoplication, and it's still a reproducible procedure that can be replicated. It's a day case surgery. And then, you know, I think initially I was asked just to come along and talk about reflux stop. And I guess this is why both the side effects of fundoplication and the dysphagia from, or potential dysphagia, you know, I still advocate links, and I'd still put it into patients, and we still offer these 3 operations, and I try and give a balanced view. Fundoplication is the gold standard. I've got data up to 15 years or longer. There's no foreign body. Links, I've got data on 40,000 patients. I've got longer data in the UK, up to, you know, 8 years. It's NICE approved. I've got safety data on that for a reasonable time, but it's still a foreign body. And then, but you can perhaps see why the attraction of reflux stop, because it's, you know, it's hoping to reduce those side effects even more, but provide a durable procedure. But I can't yet give you the data. It's being offered in Southampton as a new procedure, and it is exactly that. It's a new procedure. We've done 7 operations, and yes, they have been successful, and yes, they've had resolution of their reflux, and yes, we haven't had any intraoperative complications. But, you know, that's 7 patients, and probably in the UK there's probably been 50 operations done, and there's 1,000 operations done worldwide, and it's going through the appropriate regulatory. It's been submitted to NICE, and I imagine it will go along a similar pathway as links, as in it will get you know, a short-term approval within a, you know, specialist centres, auditing their data, and then hopefully it will go on to get full approval if it does what it promises to do. So it does the 3 things that we're talking about. It puts the lower esophageal sphincter a long way into the abdomen. It recreases the angle of His. And then the question comes, why do we put the ball in? You know, can't I just do the operation that I've just talked about, which is mobilizing the esophagus, putting the lower esophageal sphincter back in the abdomen, recreating the angle? And that's the same for all those operations I've talked about: fundoplication, links. And then why do we put the ball in? Well, the ball, one, it's going to stop it going back up into the chest, is the belief. It stabilizes these 3 things that we've done. So it keeps the angle of His in the right place, and it keeps the lower esophageal sphincter below the diaphragm. So the procedure is, as I've just described, those 3 things. So it's mobilizing the esophagus, repairing the diaphragm, recreating the angle of His, which, you know, most people would argue are done certainly with the anterior partial fundoplication. So those procedures are done, and I do every time. You don't recreate the angle of His for a links, and then you put in the ball, which is an inert silicon ball, just smaller than a ping pong ball, to give you an idea of the size. And I'll just show you some pictures. So just in the back there, you can see the white sutures repairing the crura. We're just at the point where we've just sutured the angle, the stomach, back to where it should be. And it's a very, they tried to make sure that it's done the same way, whatever surgeon you have. And it kind of explains, it's a very formulaic procedure, which surgeons tend to like. I tend to like, so that we know what we're doing. And we've sutured the fundus to the esophagus, which is technically a fundoplication, but it's not a, it's you know, it's not a wrap like an anterior or a full fundoplication. And then the ball goes in. It's delivered on a instrument, and then it's sutured, invaginated inside the stomach in the fundus. So it's buried. Now the design of it, again, it's a foreign body, and in technically any foreign body, whatever gets put inside you can move around. So it's designed, it's in 4 parts, and you suture it together. And if it was to erode into your stomach, then it would go into 4 pieces and you'd pass it out in your stool. So that's why it's designed the way it is. And then you can see on the x-ray that it's just, the chat is just flashed up, but I'll carry on. You can see the ball is this white little ping pong ball, and it sits just at the diaphragm and ensures everything's in the right place. So let's just, that repeats what I've said. You can just, hopefully there's a video. I've got enough bandwidth even in the country. So that's just showing you the sphincter that's gone up into, which, as the question was earlier, that would technically be a hiatus hernia, albeit of only a few centimeters. And this would be what would be going on inside you with the ball inside you. So the important thing is that the muscle is a long way down inside the abdomen and not in the chest. So they've got 4-year, I'm just going to present the 4-year data. They've got 5-year data, which they've shared with us as clinicians, but I don't think it's right unless it's been published to share in a public forum. So I'm just going to present the 4-year results. And they've shared the 5-year data with NICE, but we're up to 4 years. And this just describes the background that I've kind of explained to you and the kind of objective of trying to design a new instrument. And, you know, the immediate thing to say is, look, it's 50 patients with 4 years. It is 4 hospitals, so you've got a variety of surgeons. It's not just one surgeon who's very talented. It can be reproduced. And the appropriate assessments were taken preoperatively, and they've followed up with quality of life. And again, you've got data on 47 out of 50, which isn't bad. You're kind of saying, well, where did the other 3 go? You know, you can see 1 died during COVID, and then some patients, the data wasn't available. It excites us because it provides good acid control. So before any operation, we take a questionnaire, and that scores you. And most people who go for anti-reflux surgery have a score of about 30. And then at 1 year and 4 years, they've got low scores. So they're not getting problem with regurgitation. One of the, you know, the longer term issues that we showed you in the other issues is of regurgitation. And again, these are favorable. You know, we talked about 90% with Fundo, and perhaps, yes, they've got 95% in this trial of 50 patients, but it may be that it's of a similar level of acid control. We don't know. You know, we've got 1,000 patients across the world, and this is a follow-up of 4 years for 50 patients. There's a low usage of PPIs, and they've also done the test that you have before the operation. So not just is it the patient reporting they've got no acid, they've done the test to look at what the pH values in someone's esophagus is at 6 months, and 98% of them are normal. So, you know, they've reported that they've had no device-related problems, no dilatations, no migrations, and people's acid. But again, I'll just reiterate, it's a small number of patients, and they've currently got their 5-year data, as I said, under review. So for me, it's exciting. You know, why wouldn't, as a surgeon, I'm kind of encouraged. I can get rid of some of the side effects of the other operations, but I have to be cautious. And I would, you know, say to all the patients, including, you know, the first patient I operated on, who was very brave and wanted to kind of do some press around it, was had a good result, and we hope all of them will do it. We in Southampton have been given permission by our new procedure committee to do 10 procedures, and then we'll review it critically with my colleagues. One of your ambassadors, Tim, will come and check. And, we went round the patients today. And, if we don't think it's right, we won't continue. And we'll make that data available for patients. So I think, in conclusion, I think it's worth saying what the NHS and what Heartburn UK are doing and have done in this space. So I think, the UK can be proud. We have done Arrow, which Heartburn, I think, UK supported, and that showed how different surgeons are doing different things across the UK. We're then moving on to the Gulf study, which again, Southampton will take part in, and that's based out of Oxford, being led by one of your trustees, Shiraz Marker. And that is going to compare links with fundoplication, because although I've shown you data about links and I've shown you about fundoplication, those two operations have not been compared. And, while I've shown both show good results, I've not shown you which one is better. So that is a question which the UK will answer. And there's one further trial, which again, your trustee, he's quite a busy guy in the research space. Shiraz has set up a trial of reflux stop versus proton pump inhibitors. So a specific group that have been particularly badly served in reflux is people with dysmotility of the esophagus. So, and they can't have a LINX, and they probably can't have a full fundoplication. And when I say they can't, you can always find a surgeon somewhere who might do it, but the cautious surgeons amongst us would advise you against if you had severe dysmotility of the esophagus. And we might offer a partial fundoplication, but we are looking, and patients are looking, for something in that space. So it would be a comparison of taking a proton pump inhibitor versus that's under review and funding. One thing I would also kind of highlight is the National Hiatal Surgery Registry. Every single patient that I operate on, whatever operation they have, they go into this registry as long as they're happy to have their data stored at Augis, which is our association. And they get an email at 6 months, a year, 2 years, 3 years, 4 years, and 5 years. And they fill out the questionnaire that they filled out preoperatively. And then that gets emailed to me, and it kind of highlights to me my data. And, if you're considering hiatal surgery, I'd probably ask your surgeon, do you put your data into the hiatal registry? If not, why not? And can you show me your data? Because, the data's there and it's anonymized. And you can see how many your surgeon's doing, because I think it is surgeon dependent. It is related to high volume and high quality centres. We should be exploring new technology in a safe and appropriate manner. And, you need to know that you've got a unit that will act if there are problems or failures straight away. So I'll open it up to the floor. I went a bit over my time, 30 minutes, and hopefully we've got a patient who might explore. And then I can always fill time. I might be able to show you a video.
Thank you, Fergus. We've got a couple of questions. I don't know if our patient's joined yet. I think Jess will tell us in a minute, but I've got a couple of questions for you from Gay. And she's asking, are you able to comment on the stretta? And also, in fact, let's answer that one first, and then I'll go to the next couple of questions.
Yeah, I have no experience of stretta. I have referred one patient to stretta in someone who I believe is still doing it in Poole and Bournemouth. I think it's a little bit unfair. I haven't got the data to show you, but someone said it's a procedure that is confined to history. And he's an endoscopist from the Cleveland Clinic, and those were the words he used at the European Foregut Society. So those aren't my words, but they were a considered opinion from an expert in endoscopic procedures. I think there is, to move on from stretta, so I wouldn't recommend it. I'd ask for the data and I'd ask for the evidence behind it if you were considering stretta. I've only had one patient who has ever asked for it, and then I've referred them on to someone who was still doing it.
I just,
oh, sorry,
endoscopic.
oh, sorry, I was just going to, excuse me, ask Fergus, would you stop sharing your slides if you don't mind, if you're done, so we can hopefully see a few more faces if possible. Anna has joined, I believe, our lady that's had the reflux stop. So just to let you know, that if you want to carry on down the chat for now, or
I'll carry on down the chat, but just know that Anna's there if you've got any questions for Anna as well, if that sounds okay. And you can either raise your hand or put your question in the chat. So another question, will reflux stop be considered for someone for whom PPIs no longer work due to which have developed Barrett's esophagus?
Yes. So they're the patients that are considered for anti-reflux operation. They've failed medical treatment, or they're getting, as we term it, breakthrough symptoms on proton pump inhibitors, and we would, I would offer them all three operations.
Okay, thank you. And we've got another question. Thank you very much, Mr. Noble. I was wondering if reflux stop would be indicated in an otherwise healthy 63-year-old male post-ESD of stage 1B esophageal adenocarcinoma and who is now under regular EUS and scan surveillance for the past 2 years with no issues apart from some ablation of Barrett's Islands. And if there is not enough evidence for reflux stop yet for this cohort, would this be taking place? Are you aware of any research done in this kind of in this kind of patient cohort for Nissen fundoplication? Sorry, that was quite a long one.
Yeah, I mean, the important thing is that he's still able to get surveillance of his esophagus. Is this someone who I'd want to do in the first cohort of patients with a new procedure? No. Is it possible? Can you have ablation with links? Can you have ablation with fundoplication? Can you have ablation with reflux stop? Yes. Are you going to have a change in the anatomy of all three of those operations? Yes. Ironically, the one that you would initially think would be the best is fundoplication, but you'd need an expert looking at your esophagus afterwards, because actually the fundoplication potentially would distort the anatomy the most and make the surveillance the hardest. Because you want a clear run at your esophagus rather than having a wrap that's gone round. But if you're getting reflux, you can potentially have an anti-reflux operation, yes, even once you're all clear. As they said, that's a different question regarding the surveillance of a T1B, and a little bit will depend on all of your levels. And you will have had all of those consultations, which is probably difficult to go into tonight.
Radhika, did that help? Yeah. Hey.
But you can talk to you'll be under a team that can go through it, and there's risks and benefits. One thing we didn't touch on, and it wasn't in my indications, but you've kind of brought it up, which we'd love to say, oh, anti-reflux surgery stops the progression of Barrett's, and it stops the progression of esophageal cancer. And we tried to answer that question, and that's a whole different lecture around, can anti-reflux surgery stop cancer or Barrett's progression? And the answer, in short, is we do not have the evidence to support that. And that's kind of supported in the fact that we only do 4,000 operations in the UK. Otherwise, we'd be doing all 20 million of patients with reflux to stop them getting cancer. So we don't have the evidence, and specifically they looked at it a couple of years before by the fellow who preceded me in Adelaide, which is probably the best paper looking at Barrett's, and no, anti-reflux surgery didn't. Despite the kind of common sense that you all know from Heartburn UK that the biggest cause of cancer is reflux, and specifically repeated reflux over a long period of time is, that is the biggest cause without a doubt. So the common sense approach, I'm afraid, we have not been able to prove scientifically. But there we go.
Thank you. If interested in pursuing reflux stop surgery, do you have to live in Southampton to be considered, and can it be carried out privately now if not?
You don't have to live in Southampton. There's going to be a number of centres in the UK that are going to do it. Tony Blair, patient choice, so you can decide. You go to your GP and you say, I would like to go to Southampton, I'd like to go to Chelsea and Westminster, or I'd like to go to Imperial. They're the 3 NHS centres that are now doing it. And there's, there will be more centres, hopefully, which is encouraging, that the medical community kind of believe in it enough. And that, they're not centres that want to, in simple terms, be associated with a duck. We believe this has got potential to be a winner, and hopefully, change the face of reflux. And perhaps we will be doing some of those patients in the gap who haven't got the severe, but we can give an operation with less of the side effects. So no, you can either do it through patient choice or choose one of those centres. I think the furthest referral I've had is Islamabad, and they've not decided whether they're coming to see me, but I've offered them a video. In terms of private, we're doing them in the NHS, so they'll be done at Southampton General Hospital for the foreseeable future. Because there's been interest, the private patient person asked me if we would do them privately, and we could potentially. I don't think there'll be any advantage of doing it privately, other than you may be able to get it done slightly quicker, but you'd get the same room, you'd get the same anaesthetist, and you get the same surgeons. But yes, you could potentially have some of the workup done privately and then join the queue in the NHS. I don't think, we're a fairly efficient hospital in Southampton. We try and squeeze people in as they can. I don't think it's a bad thing to wait a little time with reflux surgery. I think on average, people from the time they get referred from their GP have surgery within a year. And I think, you want a bit of cooling off time. So they come and see me, they get an appointment, say 4 to 8 weeks. I send them off for the 3 tests that they need. And then they come, that takes about 3 months. So we're already up to 4 or 5 months. And then I put them on the list, and then we sort out a date within 3 to 6 months. So all in all, it's about a year, and we have to squeeze it in around the esophagectomies we're doing. They kind of take priority, and then we clump them together and we do them as a, on Monday and Tuesday. We did 2 on Monday and 2 on Tuesday. And then they get done. So it seems doable.
Anna, oh, sorry. I was just going to say, Anna, not to put you on the spot, but are you happy to share a little bit about your experience and why you opted for reflux stop? If you're not, please say. And then if anybody just might have any questions for you.
Yeah, of course. Can everybody hear me?
Yes, and thank you for joining, by the way. Thank you.
No, not at all. It's a pleasure. I'm always happy to be a test case and share my experience, because as I don't know if it's Professor Noble or Mr.
Yeah, it's Fergus is the best.
Oh, okay. As Fergus has said, it's a newish procedure, and I've been hassling for the 5-year data myself from the clinic that did mine, and we don't have that yet. So all I can go on is what's out there and what I've heard from other people that I know who've had it. I was put on PPIs after a diagnosis of Barrett's. It's quite a small segment. And I was happy for about a year. After a year mark, I started to get other effects. It seemed to me the PPI stopped working, but actually with this kind of a kind of coming together of different effects. So I know we're not going to go into SIBO today. Kind of go and look it up if you wish. I had this SIBO infection, which is small intestinal bacterial overgrowth, lots of bloating. I've got dysmotility. I mean, it was just it was a horrible kind of situation. And unfortunately, the NHS didn't really seem to want to refer me for any sort of surgical discussion. They wanted to, in their words, optimize acid suppression. And I thought, well, I'm not sure I want to do that. Let's go and explore other options. And at the time, I decided to go to a private clinic. Won't mention the name, but I can share it if wished. I'm not advertising here. The options were put on the table. Obviously, one of the options is to stay on medication. That's always an option if you're happy and you don't have any bad effects. Very personal choice. For me, I was interested in something surgical because I really wanted to come off PPIs. I didn't feel like they were making me any sort of healthier. I knew that I wouldn't get on top of some of the other issues, sort of suppressing the acid. So having had all the various tests and discovering this weak motility, reflux stop seemed the most appropriate surgical treatment. And I think the surgeon had done 7 or 10 before me. So yeah, went for it. And I won't lie to you, it took me a good 6 months to start feeling the benefit. So if anyone's going to go for it, be prepared to give it time. Everything has to settle. But after that, you know, I'm 2 years on in December and I've never looked back. It's been brilliant. I had a PH study about 6 months after the surgery and it showed 0 pathological reflux. I don't have heartburn. I don't really think about it anymore. I got on top of some of the other issues. I have to eat smaller meals. I'll be honest, you know, must have other gut issues going on. And I think some people probably also have that and don't know. And the more I think about it, the more I wonder if there's concomitant factors. I don't know what the word is, but I'm sure there'll be people who have other things going on like gastroparesis or the SIBO or other things. And I don't know if that's well known across the kind of patient group. Anyway, so it's taken me a while to get to a kind of level with that. But yeah, at this point, I'm really, really happy with it. Yeah, really good decision. And I know it's a big decision and it's not for everyone. And if you're going privately, it's very expensive, but a positive experience from me and the people that I've spoken to that have also had it, I would say in general, they're happy they did it. So, and I had my 3-year scope in April or May or June. Anyway, in the middle of this year, I have 3-year scope for Barrett's and there's 0 changes really. In fact, when I compare it to the initial diagnosis, I think it's dropped 0.5 centimetre. So there's nothing to indicate a change in that respect, which is great. So hopefully that's enough of a potted history. I'll answer any questions from a patient perspective now, or they can be sent to me later. I don't mind. I'm always really willing to help.
Well, thank you, Anna, and thank you, Fergus. I've got another question in the chat, and then please, if there's any sort of other questions for Anna or Fergus, that would be great. But thank you. That was a great potted history, and I really appreciate that. So I've got another question here for Fergus. Thank you, Fergus, for your interesting talk. This is from Sue. May I ask, is reflux stop surgery suitable for a patient who has previously had a Nissen fundoplication, which seems to have failed?
Yes. is the simple answer. You need a full workup. You need to come and see one of us and get assessed, and then we can talk to you. It's not something to be undertaken lightly, and you'll need all of the tests that have been described. You'll need a gastroscopy, a pH manometry, and you need a history and proper examination, and then potentially, yes. There are patients that are coming having had links or fundoplication and asking those questions. It will be more involved surgery, any revisional surgery is. But yes, you'd have choices of having a revisional fundo or reflux stop, probably.
Okay. Thank you.
Can I kind of move it on to Anna? It's so yes, I always, can I interview you perhaps? Because I was always interested. The first patient who I've done some other new procedures. You never get taught when you're at medical school that you're going to actually continually learn for the rest of your life. So I'm a year 7 consultant. I should be in the peak of my powers and everything should be easy. But since starting surgery, I've learnt links, reflux stop. I'm being proctored in. I've done robotic surgery. I've done laparoscopic surgery. It keeps moving. But what made you kind of be the one who was also still moving, as it were? Why did you go? Those links, I've just shown data that links is okay. There's percentage that probably get dysphagia. I've shown you fundo is okay, but quite a lot of them possibly get a bit upset, and you were like, well, I don't fancy those. Why did you go for the new one? And there's good data and there's good centers doing it. Why did you go for reflux stop?
I think you're right. That kind of ripple of fundoplication, the tradition, the gold standard, the issues with it, as I understood them, with burping, not being able to vomit, I think it kind of put me off. And the fact that some people have reversals and all sorts of things, and I thought, I'm not sure I want to go through that. It seemed a bit much. I was interested in links until I had the manometry and it showed this weak motility, and the surgeon that I saw said, yeah, you might be one of those people that have dysphagia. I wouldn't, did he recommend it? He totally sat on the fence, and he was like, well, it's your decision. I'm like, thanks for that. And then reflux stop was the option that seemed. I know there's a lot of shiny publicity around it from Implantica. I think that's the business that make it. But I looked at the theory behind it, the studies that have been done on it, and I thought, do you know what? It ticks a lot of boxes. You can still burp, which is great because I burp a lot. You can still vomit. There's much less chance of dysphagia, certainly significant. And a lot of the safety features, it can sort of break up if it's ingested, all this sort of stuff. And I thought there were enough people that had it successfully that made me think, okay, this is what I'm going to go for. Well, you don't make any decision lightly, but I think I have probably the bonus of having a scientific background, so I kind of understood a lot about the anatomy, physiology. I could interpret some of the scientific data, so maybe that was an advantage. I don't know, but it seemed to be a good bet at that point. That must have been about 3 years after I think the first had been done in the UK, so there was just enough people to think, yeah, okay, go for that.
We're grateful along all of these as we try and move forward. There's patients that are willing and they have it done in a correct way. I have reassurance that they as a company are doing it in the correct way. which is reassuring for me as a surgeon that they seem to be. And but it's still, there's still always a bit of nerves. Probably you felt, thinking, who else is there out there? But well done. I'm glad you've had a good result.
Thank you. Yes, me too.
Another question in the chat from Jane to Fergus. How would you, as a patient, persuade your GP to make a referral? My experience so far has been a reluctance to refer on even for endoscopy. It took a year for me to get endoscopy and diagnosis of Barrett's, and then I'm still under GP care until next surveillance endoscopy. So is there any advice to how might speak to GP?
I just tell them. It's very difficult. You know, they are the purse string holders, but it's can you self-refer? No, not really. They do the budget. You just need to ask them. You say, look, I'd like to explore surgery. I don't wish to take, you know, whatever your reason is behind it. You're getting breakthrough symptoms on proton pump inhibitors, or you're getting you don't want to take proton pump inhibitors for the rest of your life. You can just ask. I'm surprised, as Anna kind of alluded to, we've entered a new world of medicine where we kind of are in partnership with the patient, and we are here to give an opinion. Hopefully we're not too sat on the fence. We're here to give our expertise and opinion. You do not need to take it, but you know, sometimes we do have to lay it on the line and give an opinion. But it's a decision for the patient. You know, you can ask as many questions. You know, we may get into the realms when you go around and see lots of surgeons, and I wouldn't see too many surgeons. You know, you can see a couple. You know, you do get in private practice lots of patients you kind of realize are going round and grazing for opinions, as we call it, which can be quite dangerous. But you know, I'm quite happy if a patient say, oh, well, I'm not happy with your opinion, I'll even refer for a second opinion. So I don't see how a GP can refuse you. They just can't. You can, you know, I don't know how GPs are getting away with not referring. Seems strange.
I'm just thinking it might be worth, you may have done this already, Jane, but it might be worth asking to see another GP as well, if you're having no joy with your own.
Because you know, you're sounding like you've got Barrett's, you've got reflux. It's all slightly bizarre, but you need to see all of the picture. And if you're under surveillance, you could even get the gastroenterologist, who's whichever surveillance program you're on. You could write to them is another way. It's a bit sneaky. You know, you could ask there's normally a nurse endoscopist who is looking after the list and say, look, I'd like to get a surgical opinion, consult. It doesn't commit you to anything. You know, oh, you're going to see a scary surgeon and they're going to obviously talk to you about surgery, but you're still in the driving seat and you can make a choice.
Hopefully that helps a little bit, Jane. Any other questions for Anna or for Fergus?
We also know most of the GPs. I don't know how far people are, but sure.
Yeah, maybe get in touch with us separately, Jane, and see if there's any other way that we can help. Maybe email us and we'll just, in case you are in Fergus's neck of the wood, and we might be able to help.
I think the only other thing to think, you know, as Anna kind of alluded to, and perhaps, you know, there is a little bit of education that needs to be done with these newer procedures. You know, you have to be wary until you've got the full data, but there's definitely a belief in some gastroenterologists' views that, you know, fundoplication in their centres weren't providing results, you know, they would limit the referrals to have a surgical consultation because their views of fundoplication surgery was of all the side effects. And there probably is a, you know, as these new procedures come out, then they need to be explained, and we need to be able to provide robust clinical data to support our belief that the side effect profile is less, so that patients do come through and at least consider it, and then they'll make a choice.
Thank you. Anna's saying I couldn't get an answer as to whether a capsule sponge procedure could be done with the reflux stop. Fergus, do you know? That's a good question. Thank you.
That's a really good question. I mean, I would ask the I'll ask Implantica for you. There's no reason technically. I'd certainly leave it. You know, it's the magic 6 to 8 weeks of bone healing and everything. You know, but go and see a doctor. How long does a cut take to heal? How long does a break? It's always 6 to 8 weeks. Come back and see me in 6 to 8 weeks, and everything's better. So you'd want to leave it, you know, realistically 3 to 6 months afterwards. It's, yeah, you know, there's no reason why you wouldn't have it after a lynx or a fundoplication. So there's no reason, I suspect, that you wouldn't have it after a reflux stop, but I'll 100% confirm, as I don't know the answer. There's a few things that are happening which are kind of sneaking up on us. Is the fact that there's a whole tranche of the population on GLP-1 inhibitors, the Wegovy, the obesity drug that we, you know, now that's become a standard question we need to ask because GPs aren't prescribing it, they're getting it elsewhere. So there's a few things we're having to kind of pick up on. You know, you want to know that they're on these drugs before you operate, rather than finding out afterwards. But we can ask about the capsule, and they could perhaps put something on their website, which is very shiny, as someone pointed out. I think it's good, and they're, you know, it's, in a way, it's reassuring that they're a good organisation.
Thank you very much. I think if there's no more questions, we're probably up to time. But if there are any more questions, do pop them across to us, email them across to Jess. And I'd just like to, you know, sincere thanks to Fergus for your time and for sharing your expertise with us this evening. Big thank you to Anna for sharing your experience, to all of you for joining, and to Jess for helping organise so well as ever to make it hopefully a positive evening for you all, and a positive learning. If you have got any other questions, or if there's any other topics that you would like Heartburn Cancer UK to try and get an expert speaker session on, then again, please do pop them across, and we'll be really glad to see if we can sort something out for you. We'll look to have a programme of different expert speakers for 25. We've got some people lined up already. Certainly know we've got one coming up on hiatus hernia. We've got something coming up on diet and nutrition. We know we have something on the TIF procedure. So yeah, there's more coming up for next year, but do pop across anything to us, so that we can try and get other expert speaker sessions organised. And there's a few thank yous in the chat there as well. So thank you very much.
Very good. Shall put the kids to bed.
Oh, they get to stay up. Thank you.
Thanks, everyone.